Good morning. So the topic we are going to cover includes dermatome, fingerprints, modifications of deep fascia and principles of skin incision. So the first competency is describe dermatomes in the body. Dermatomes, the area of skin supplied by a segment of spinal cord or a pair of spinal nerves is called as dermatome. Dermatomes are clinically important. Lesion to a spinal nerve will produce a characteristic loss of sensation in that specific area. Dermatomes overlap in their distribution. For example, the affection of herpes zoster, which includes vesicular rash, is limited to one dermatome and runs along one spinal nerve. Each spinal nerve except the first cervical nerve receives sensation from specific area of skin called the dermatome. As the dermatomes overlap in their distribution, when one sensory nerve root is severed, complete loss of sensation is not seen in the dermatome. It is required to sever three consecutive sensory nerve roots to produce complete loss of sensation in one dermatome. Spinal nerve lesions are assessed clinically by testing the dermatomes for crude touch and fine touch sensations. The level of sensory loss is indicated by dermatome that is or affected. Dermatomes also indicate the level of motor loss. Then the second competence is dermis and fingerprints. Dermis is deep to epidermis. It is mainly composed of collagen fibers. It has blood supply. Nails and hair follicles are embedded into the dermis. In the face skin, the muscles of facial expression are inserted into it. The boundary between dermis and epidermis is wavy. Upward rising waves of dermis are called as dermal papillae. Downward epidermal waves into the dermal papillae are called as dermal ridges. Raised dermal papillae produce raised areas between the furrows. In the fingers, the wavy dermal papillae form frictional ridges to produce the fingerprints. You can see in the picture the fingerprint. Then we go to supercell fascia along with fat distribution in the body. Supercell fascia is a thin mesh of connective tissue filled with fat or adipose tissue. It binds skin to the deep fascia, which is deep into it. It is dense in the scalp, back of neck, palm of hand and sole of foot. The other parts of body, it is loose and is of elastic nature, allowing for pinching of the skin. The thickness of superficial fascia varies depending on the content of fatty tissue in it. It is thin in eyelids, nipple, areola and male external genitalia. It is in a well-nourished body, the superficial fascia or superficial fatty fascia rounds off the counters of the body. Its distribution varies in the sexes. The smoother outline of a woman is because of greater amount of subcutaneous fat, which is a secondary sexual character. Insulating layer. As fat is an insulating layer, females are capable of withstanding mild to moderate cold. The insulation is overcome in hot weather by large venous flow away from skin, which is restricted in cold weather. Supercell fascia contains small blood vessels, lymphatics, and nerves, and at some places lymph nodes. Modifications of deep fascia and its functions. Deep fascia is dense and inelastic connective tissue. It separates the deeper structures from the superficial fascia and skin. It is devoid of fat. It is well developed in limbs and ill developed in the trunk. Functions: it gives attachment to muscles, modifies to periosteum, anchoring muscles firmly to bony prominences, separate muscles into compartments, for example flexor and extensor based on function. Near the insertion, the flexor and extensor muscles, it thickens to form bands called retinacula. Retinacula restrict the tendons from flying away and help to change the direction of the pull of the muscles. Compression of the compartments during contraction of muscles help in the venous drainage. Deep fascia of the leg plays a major role in the venous drainage of the lower limb. So you can see the modification, that is retinacula. It forms aponeurosis of flat muscles. It forms retinacula where the tendons curve on the way to reach their attachments in the wrist and ankle. Forms ligaments where forces tend to separate bones of a joint. The ligaments are strong, inelastic, fibrous bands of deep fascia that bind the bones together. Coming to modifications again, ligaments are similar to tendons, but their margins are not well defined, as they do not slide over the surrounding structures as tendons do. It forms endomysium, perimysium, epimysium. These provide passage to blood vessels, nerves, through it to reach deeper parts of the muscles, nerves, organs, etc. Then principles of skin incisions. Surgical incisions are considered to be appropriate if in line with Pinku's main folding lines or Krizel's anti-muscular lines or Bogue's relaxed skin tension lines. These incisions will achieve minimal scar formation. Langer lines. Langer derived the concept of cleavage lines from his cadaveric study in rigor mortis. Langer lines run perpendicular to most of the skin folds. They run vertically in antecubital region, wrist, thigh and tibia region. Felix Pinkus questioned the use of Langer lines and instead described main folding lines. Krizel in 1950 proposed distinct lines which oriented perpendicular to the action of underlying musculature. Then Bogues described relaxed skin tension lines of the face in 1984 and of the body. These lines followed furrows produced by pinching of skin in different directions. So pinching technique was suggested by Pinku and Krizel, but is likely to be variable depending on the age of the patient and also the technique applied while giving incision. Some authors think that Bogues and Krizel lines, not Langer lines, may be the best guides for selective incision of the face and body respectively. Thank you.